is the addition of bevacizumab to conventional therapy and its improvement in progression-free survival in HER2-positive breast cancer, presented by Dr. Luca Gianni, Director of Medical Oncology at San Raffaele Cancer Center in Milano.
Thank you, Lisa, and good morning, everybody.
This is a time when options for treating women with HER2-positive breast cancer are really many and very effective one. One of the possibilities is that of improving by adding modulators of the activity of HER2-directed therapies. And at these meetings over the years, there have been the presentation of evidence, both preclinical and clinical, indicating that there is a rationale for combining bevacizumab, which is the anti-angiogenic monoclonal antibody directed against the VEGF, with trastuzumab. Indeed, VEGF expression is positively related by HER2, and the levels of the VEGF correlate with HER2 overexpression. And in animals and in animal models, the combination of the two monoclonal antibodies produced synergistic results. In addition to that, a single-arm phase 2 studies of trastuzumab and bevacizumab with or without chemotherapy in women with locally recurrent or metastatic breast cancer showed encouraging activity in spite of progression with trastuzumab containing chemotherapy. All of this has justified the conduct of a prospective randomized trials that is known as AVEREL. AVEREL randomized women with 424 women with previously untreated HER2-positive locally recurrent or metastatic breast cancer to receive either the conventional treatment of every 3 weeks trastuzumab with docetaxel at the dose of 100 mg per meter square, or the same combination of chemotherapy and trastuzumab with the addition of bevacizumab given at 15 milligram per kilogram every 3 weeks. Treatment was planned until progression of disease or intolerable toxicity, and in the case of docetaxel, there was a suggestion to try and deliver at least 6 cycles of chemotherapy, knowing in advance that it is usually difficult to proceed beyond the 6th cycle with this type of chemotherapy. The primary endpoint of this study was the investigator-assessed progression-free survival. Secondary endpoints were additional efficacy elements such as overall survival, objective response rate, duration of response, safety and quality of life. And finally, there were exploratory endpoints, the most important of which was an independent review committee assessment of progression-free survival to comply with regulatory recommendations in the United States by the Food and Drug Administration, and a biomarker assessment. And the participation to this biomarker assessment was optional. Let's go to the results without dwelling too much into the characteristics of the patient's population. That was classical for HER2-positive metastatic breast cancer at first presentation. If you consider investigator-assessed progression-free survival, that is the primary analysis of this study, you can see that administration of bevacizumab prolonged the progression-free survival for median 13.7 months to median 16.5 months, and that the difference corresponded to a hazard ratio of 0.82 and a p-value that was not statistically significant of 0.0775. If you consider the independent review committee assessment of progression-free survival as done per US regulatory purposes, again you observe the same, or basically the same difference from 13.9 to 16.8 month of progression-free survival. You have to consider that the most relevant difference in this assessment by the independent review committee was that patients were censored for non-protocol therapy, something that was not done in the case of the investigator's assessment. In this case, the hazard ratio stratified was 0.72, and the p-value was statistically significant. It was 0.0162. The improvement is there. However, we wanted also to know if there was a subset of cases and patients who derived benefit out of the entire population. And to do so, we repeated the same study that has been conducted in HER2-negative disease, and starting from the concept that a high expression of vascular endothelial growth factor A is associated with poor prognosis, we wanted to know whether this, the measurement of vascular endothelial growth factor A could be a marker of a subset of patients who might derive more benefit than others. Here you see from this line what is the progression-free survival in cases that were exposed to the standard docetaxel and trastuzumab therapy and had low vascular endothelial growth factor alpha. If they had high VEGF alpha, as you can see, the median progression-free survival was only 8.5 months. However, in both high and low VEGF alpha, administration of bevacizumab corresponded to an abrogation of the poor prognosis, and both patient groups had a more than 16-month progression-free survival. These numbers are not statistically significant and couldn't be because the study was limited to a subset of the entire patient population corresponding to about 160 patients overall, but they are really interesting because they are the first evidence that in this population of HER2-positive cancer, we have the same behavior that has already been observed in the AVEREL trial in HER2-negative disease. In conclusion, the AVEREL demonstrated longer median progression-free survival when bevacizumab was combined with trastuzumab and docetaxel in patients with HER2-positive metastatic breast cancer. The difference in terms of primary endpoint was not statistically significant, while it was statistically significant when assessed by an independent review committee. The data on overall survival that I didn't show are really immature because it's too early to derive any conclusion on overall survival. At this time, the two curves of overall survival are not different at interim analysis. There were no new safety signals observed in this patient population with respect to what we already know from other patient populations exposed to Avastin. In perspective, in the AVEREL, exploratory analysis of plasma VEGF-A suggests a potentially predictive effect with greater benefit with high VEGF-A levels that are consistent with observation in the HER2-negative group of patients. Because of that, a global biomarker study known as Meridian is planned, where patients will be treated with bevacizumab plus paclitaxel and stratified by plasma level of VEGF-A to confirm or dispute the concept that this marker has anything to do with prediction of benefit from addition of bevacizumab. And on top of that, we have now that has been completed the BETH adjuvant trial, where in HER2-positive disease, patients were randomized to receive chemotherapy and trastuzumab with or without bevacizumab, and this will provide additional evidence on the potential benefit of adding the anti-angiogenic monoclonal antibody in women with HER2-positive disease. Thank you for your attention.
So thank you, and we can all thank Dr. Gianni for now providing data regarding bevacizumab in the one subset of patients HER2 positive in which it had not been examined, and giving more fodder for the controversy. These are all open for questions.